Now we move into one of the other lethal toxicities from checkpoint inhibition, which is myocarditis. This has gotten a lot of attention recently, not only from high-level publications, but because, unfortunately, among all the toxicities, thankfully it's rare, but it does have a high fatality rate, as I think we'll hear. So Dipti Gupta has been a cardiologist in our group here at Memorial and has seen a number of these patients, and will be sharing her experience with myocarditis and probably a little bit on should we be screening for these patients as well, because I know I had done some research in that area. So Dipti, thank you.
Thanks, Mike, for the invitation, and congratulations to you all to make it to this point in this very long but extremely educational day. So there's an expanding spectrum of cardiovascular toxicity that we're seeing with immunotherapy. There's so many cases, case series, case reports, and now even pharmacovigilance data that Mike was referring to that is coming up with more and more diagnoses every day. So the current status is that we know that there's association of pericardial diseases, more so with lung than melanoma. There is heart failure that has been associated, both inflammatory and non-inflammatory types, so stress-induced cardiomyopathy, dilated cardiomyopathy. There are now scattered case reports about acute coronary syndromes due to different mechanisms. So even coronary vasospasm has now been noted, vasculitis has been noted, and the remainder of my talk, I'm going to actually focus on what I consider to be the most important cardiovascular toxicity related to immunotherapy, which is myocarditis. It is an inflammatory problem. It is also very ominous because of extremely high case fatality rates. So what put this really in the limelight for all of the cardiology community was this case series of two patients, both were fatalities with myocarditis. Both had melanoma, and this was published 3 years ago now in 2016 in New England Journal of Medicine. And I'm going to walk you through this first case because this is really the prototype of the fulminant cases that we see. This was a 65-year-old woman with melanoma. She'd had Ipi and Nivo, her first cycle. She presents early after her first cycle, day 12, dyspnea, fatigue, some atypical chest pain. ECG and echocardiogram are normal. Myocarditis is diagnosed with a troponin of 4. She also has concomitant myositis with a CK in the thousands. So back then, she was treated like any other toxicity would be treated. She was given Solumedrol, 1 milligram per kg. This was initiated rapidly within the first 24 hours. Despite that, she had complete heart block. Troponin went from 4 to 50. She then had refractory ventricular tachycardia. She had multi-organ system failure and death, and all of this within 24 hours despite Solumedrol. The second case was pretty much similar to this first case. The autopsy showed intense lymphocytic infiltration of the myocardium with T cells, macrophages, CD3 positive T cells, CD8 positive T cells. There was sparing of the smooth muscle. Now, looking at this H&E slide, most of us that have trained or worked in cardiac transplant centers, it brought back memories of having seen this exact slide before. And where we have seen this slide is actually in the context of cardiac transplant rejection, so allograft rejection, and we see very, very similar findings. So what we did back in 2016 when we realized that this was a real problem, infrequent side effect, but one that kills and kills quickly, we decided to sort of form our treatment paradigms extrapolated from how we treat cardiac transplant rejection. So a few things happened in 2016 and in the years following. Number one, we started to see at our institution an exponential increase in cases of myocarditis. So I'll give you an example. In 2015, 2016, I would probably get called once every 6 months for a myocarditis case. Now I get called about once a day for a myocarditis, for a screening question, for something related. The second thing that happened was we realized that in each academic center, we were trying to compare notes between cardio-oncology centers. None of us had enough numbers to make meaningful sense, either of the pathophysiology or how to manage these patients. So we decided to pool all of our patients and form a registry, which is now serving as a great resource for moving the field forward. And number three, Jed Walchuk and his group decided that they would actually screen patients to pick up subclinical myocarditis in patients that were completely asymptomatic, in hoping that we will pick up these cases early, we will intervene on them, and prevent these fatalities. So we'll come to one by one, we'll see what happened. So this was the registry data. These are the very first 35 patients. This was a case control series. Again, it's 35 patients. It's a case control series. It's the best we could do. This data was published early last year. But I will say that even though it's a very small series, it lends some very important insights that we continue to use now. So the prevalence in this study was about 1%. And I think that strikes true to most of us that have been dealing in this problem. This doubles if you're giving 2 agents or combination checkpoint blockade. Presents early, and this is a theme that has repeated itself time and time again. This is an early problem. The worst cases present the earliest, but about 75 to 80% of the cases will present after the second dose or the first dose. It is not a heart failure problem in that their echocardiograms, their ejection fractions are completely normal. So this is a change in thinking from how we think about cardiotoxicity related to chemotherapeutics, et cetera, because most of those problems have traditionally been thought of as heart failure predominant problems. This is not a heart failure problem. Most of their echocardiograms, their EFs are normal. So how do we diagnose it? Most of these patients are at risk for developing electrical instability. They don't have normal ECGs. If they come in, they have a normal ECG. What they're risk for is broadening the QRS and then going into heart block or into ventricular tachycardia. The one test that we use, and which is extremely important, is the troponin levels. The troponin levels are often extremely abnormal, and I'm not talking 0.03 or 0.04. We've seen troponin levels in the fulminant cases in the hundreds. So troponin and ECG are abnormal in over 90% of these cases. Now, that being said, I will reiterate what Bianca had said early on. This is a very difficult diagnosis, and it has to be put in the right clinical setting, in that common things are common. Even though we see these cases, a patient could be having a heart attack and could present very, very similarly. A patient could be and I have basically diagnosed the whole spectrum, everything from acute MI to PE to strokes to cardiac meds for concern for ruling out myocarditis. What we use for rule out and for confirmation is cardiac MRI. It is important to know that it requires a lot of technical expertise, and even then, the yield is not 100%, especially for cases that are not fulminant. So the yield in the best case scenario is about 50 to 60%. That's the real world data that we're going to publish soon. In terms of the biopsy, cardiac biopsies are not a benign procedure. There's risk for perforation, especially high if you're in the midst of an inflammatory process such as ICI myocarditis. Again, not something that we take lightly. Those are the 2 tests you can use for confirmation. You can also confirm by other means, which is biomarkers and looking at the clinical picture. Now, myocarditis usually keeps bad company in that there is always non-cardiac immune toxicities that I like to look for. Bianca mentioned before, I will reiterate, the triad of myositis, myocarditis, and myasthenia. I will warn everyone in this room to watch out for this triad. Whenever we find one, we screen for other things. And most of the fulminant cases that we see, one thing that always catches my eye is myositis and myocarditis traveling together. So in this study, again, 35 patients only, but during a 100-day follow-up, 1 out of 2 patients had an adverse cardiovascular event. And these were hard definitions. It was defined in this study as cardiovascular death, cardiac arrest, cardiogenic shock, or complete heart block requiring pacemaker. And troponin was important not only for diagnosis, but was also the only important prognosticator, such that if your discharge troponin was greater than 1.5, your chances of having an adverse event were 4-fold higher with a 95% specificity. In this small study, we noted a trend that higher initial steroid dose led to a lower troponin, to a lower MACE. But we had not, this was again, just a faint signal we picked up. 8 out of 35 patients in the study were on IVIG, infliximab, CellCept, and ATG. So now, come 2019, a few years later, this registry has now grown to almost 140 patients. Now we have sites not only in US, Canada, but also Europe. So there's 23 sites now. And this is unpublished data that is going to be under review soon. And what we show here, we basically looked at steroid dosing. Of course, that is a concern. It's been a concern of mine. A lot of these patients in my clinic that I follow, we cannot get them off steroids. And if we do try to get them off steroids, despite biologics, sometimes we encounter biochemical recurrences. So it's been a continuous sort of struggle for us to figure out if this is really the right dose of steroids. We're pulsing them, and then we're continuing on these high dose of steroids. So this data showed, or at least gave us the signal, that indeed it is important not only to give high-dose steroids, which is in this study defined as half to 1 gram of Solumedrol, but to give it within the first 24 hours, and that makes a huge difference, at least in their cardiovascular outcomes. So similarly, of course, dose and timing here interacted, but the interesting part was the timing was even more important than dose in that interaction, such that if you waited 3 days to give a gram, it's not really going to do very much. All right, so I just wanted to touch on this. We use infliximab quite often. Even in the registry, a lot of patients have gotten infliximab. Of course, there's great data in colitis, like was shared earlier on, so it's a go-to medication. But there's always this black box warning that seems to be a deterrent to use infliximab in myocarditis cases. So I just wanted to go over this story just for a second. So TNF-alpha is elevated in heart failure, correlates with the severity of heart failure. It's a negative inotrope. Cytokines are bad in heart failure. This has been known for decades and decades. So what happened was multiple randomized control trials were designed in the early 2000s, almost 2 decades ago, to see if anti-TNF therapy is going to actually improve heart failure outcomes. So they looked at etanercept. There were 3 trials designed, looking over 2,000 patients. All trials were negative. There was only 1 trial with infliximab, which was a very small trial, which was called the ATTACH trial, which looked at placebo versus 5 milligram dosing versus 10 milligram dosing in patients with advanced heart failure. And what they found was that while infliximab did well with the inflammatory markers, and they might even be a signal of improvement in heart failure status at the short term, the 14-week time point, at the 28-week time point, the inflammatory markers had gone back up, as you would imagine, because they're not getting continued therapy. And they also found that with the high dose of infliximab, there was actually increased risk of death and heart failure hospitalization. Again, there were only 50 patients in each arm, so it was a very small study. These results have never been replicated, but enough to give the FDA warning that infliximab should not be used with heart failure. So as we spoke about before, myocarditis due to checkpoint is actually not a heart failure problem. It's an inflammation problem. And so I think it's completely reasonable to ensure if you have a normal EF in these patients, they're not in clinical heart failure, to then use the lower dose, which is the 5 milligram per kg dose. It has been shown to work in other non-cardiac toxicities and works pretty well for us as well. And we usually only give a single dose. This is what Anne was referring to. So in June of this year, there were 2 case reports that were published in New England Journal of Medicine. These were 2 new agents that were used for steroid refractory myocarditis in 2 patients. Let's go over alemtuzumab, which was the first drug that was used for in a 71-year-old with the Triad, so myocarditis, myasthenia, and the myositis. She was not getting better despite being on 4 agents. So pulse steroids, plasmapheresis, mycophenolate, and rituximab, and the patient was continuing to get more and more VT. Troponins were starting to go up. So day 17, they decided to give her alemtuzumab. Patient got better in a few days, was discharged home. So we decided to look up alemtuzumab. which is a recombinant monoclonal antibody to CD52, which is found on surfaces of all the peripheral immune cells, leads to complement-mediated destruction of all the peripheral immune cells, and basically they get reconstituted from your stem cells. It was approved for B-type CLL in 2004, and in 2013 for refractory multiple sclerosis, which has been refractory despite 2 drugs. Now here's the thing. If I start to read out the serious side effects of alemtuzumab, it will probably take the remainder of this conference. There is also, so the side effects are not only what you would expect, like first dose reactions or cytopenias, they're actually fatal autoimmune phenomenon that have been seen quite frequently. And if that's not enough, there's also FDA black box warning about ischemic and hemorrhagic stroke and cervicocephalic dissection that was placed on this drug last year. So due to all this risk, it is available, at least in the US, only through restricted distribution under a risk evaluation and mitigation strategy. So I think most of us will not be able to order this drug. This case report came out of Canada. The second drug that was used for another similar case of myocarditis and myositis, not getting better despite being on high-dose steroids, despite being on plasmapheresis, was abatacept. Again, this patient did well, went home, and had a 1-month follow-up, so we really don't know what happened with the tumor, but at 1 month was doing okay. So abatacept, like Anne said, is a CTLA-4 agonist. It's pretty much the antidote to IPI. Adverse events, all what you would expect, first dose reactions, respiratory complications, but tumor growth remains a concern. We have used abatacept in one of our cases across the street at Cornell. We gave only a single dose. It seemed to have quieted down at least the myocardial inflammation, but we continued all the other immunosuppression on that patient. So we have an N of 1, but it seemed to have worked. So let's come back now to see if there is something we can do to prevent to pick up myocarditis early on in the game. And for this reason, Dr. Walchuk and his team started to screen for patients for myocarditis. And the way we did that was screening troponin and ECGs at baseline and then weekly till their second dose. We published data on about 76 patients recently. They all had 6-month follow-up. The good news here is no cases of myocarditis. There were no adverse cardiac events. All deaths were cancer-related. The bad news here is that these patients are as you would expect, do have detectable troponin levels. These were all less than 0.06, but remember, these will show up as red in CIS. This is an abnormal result in 17% of these patients. All these happened when we move to a higher sensitivity troponin assay, and these assays are only going to get more sensitive. So they're going to pick up a lot of this noise, which is difficult to tease out if you're trying to, if you're an oncologist trying to treat these patients. And almost all these patients were then continued on immunotherapy without any cardiac adverse events. So this is a rough paradigm on how I think about these patients. So you can divide these patients into 3 categories. We just talked about the screening patients, so let's start with the subclinical category first. These are patients that we are screening. They're let's say a 67-year-old, completely asymptomatic patient after cycle 1 of ipi/nivo with a troponin of 0.03, a normal CK, vitals, and ECG completely normal. These patients, we will do diligent chart reviews. We will ensure there is not a real change, a clinically significant change. Most of these, most if not all, will be managed as outpatients. They will have repeat labs and ECG in 3 to 5 days, and they will continue on immunotherapy. Now let's go to the category that's the most worrisome category, but by that same reasoning, it's also somewhat straightforward in what we have to do to address them. So the fulminant category, these are patients that are hemodynamically and or electrically unstable. So this would be a 67-year-old with complete heart block after cycle 1 of nivo, blood pressure is 30, and troponin, CK, ESR are all high. This patient needs CCU level of care. This patient needs to be at a place where hopefully they have cardio-oncology services, because even having a CCU does not mean that they would identify and be able to treat this phenomenon, because like I said, this knowledge is somewhat esoteric, and this is not widely disseminated yet in the cardiology community. So these are the patients. We will pick up the phone. We will make the transfer calls. If the patient is being treated in Florida or New Jersey or wherever, we will call the cath lab. We will tell them to give them steroids. We will sort of get very involved in their care. These patients oftentimes need hemodynamic support if things go south. We've had these patients on ECMO, on Impella, on balloon pumps. A lot of these patients will end up requiring pacing. We have now sort of understood that we give them temporary pacer. We try to give them temporary pacing first, because a lot of them will recover in 3 to 7 days and will not need permanent pacing. If they're in the cath lab, we prefer that they get a biopsy, endomyocardial biopsy, since they're already in the cath lab and getting an invasive procedure. Again, early high-dose steroids, we give them a gram. We try to get that gram to them as soon as possible. We also give them Cellcept. This is sort of our new clinical guideline where we're trying to start a biologic up front. We give them 1 gram BID. We consider other agents based on clinical scenarios. The clinically significant but not fulminant, this is a growing group of patients now due to increasing awareness. 67-year-old with fatigue, status post-cycle 2 of Pembro, new right bundle, troponin is 1, CK is 800, vitals are completely stable. These are the patients I sometimes may monitor in the ICU and then have them step down to a telemetry floor. I will give them methylpred 2 milligrams per kg. If I'm convinced about their stability, if there are questions, I will still give them half to 1 gram. They will get Cellcept up front. The reason for doing that is A, introducing a biologic, but B, remembering that Cellcept is not something that will act the same day. It takes 5 to 7 days, but what it helps is for us to taper down these steroids rather quickly. We will use biomarkers and ECG data to aid in titration of immunosuppression. Usually I continue Cellcept 2 weeks after steroids have been completed. And I cannot emphasize this enough, that even though these cases sometimes are straightforward, more often than not, there are overlapping syndromes, and it's extremely, extremely important for us to be very diligent and try to eliminate or exclude other more common causes of cardiovascular disease. So where are we now? Fulminant myocarditis, we are getting much better. We have treatment algorithms in place. We have triage protocols in place. Screening for myocarditis, we continue to do this because we need a larger sample size. It is probably low yield in all comers, but time will tell. We are now having emerging issues of biochemical recurrence and subclinical syndromes. Rechallenge, most of these patients don't make it to rechallenge, unfortunately, but we have rechallenged at our institution one case, which was a very mild clinical case. He did well. I teed up another case for rechallenge. Thankfully, she doesn't need rechallenge. So case by case, we are open to doing that for milder presentations with extreme caution. All over the country, there are probably 4 or 5 patients that have been rechallenged, all with mild presentations, and thus far have done well. And then combination therapy. So a lot of these immunotherapeutic drugs are being now used with TKIs, et cetera. So we don't know what the clinical phenotype of that cardiotoxicity will look like, and time will tell. And that's it. This is a summary slide, but I'll take any questions.
Any questions for Dipti?
I had one of those triple threat cases to go through. Thankfully, it was not my patient, but he ended up doing it all. But what we noticed was it's in the excitement, he got antithymocyte globulin, he got all the stuff, but they stuck plasmapheresis on the wrong side of the infliximab. So that's just something to keep track of. Is just no point of doing one on Saturday and the other one on Sunday, right? Okay.
So we haven't used much plasmapheresis, at least in the context of myocarditis. I know Bianca has used a lot of that in the neuro context, but we haven't really used plasmapheresis. Yeah.
And it's very helpful to know that maybe infliximab is not such a problem to give, at least in the context of a preserved ejection fraction. We should feel more comfortable about using it. Okay, well, thank you very much, Dipti.